Good morning, everyone. I think this is the emptiest room I've seen so far, but it might be an indication of just how overwhelming the meeting has been so far. It's been such a rich conversation, so people might be a little late coming in as they try and digest all of the information. My name is Pascal Alote. I'm the Director of Sexual and Reproductive Health, which also includes a special program on research on human reproduction based in WHO. We have a wonderful panel of speakers today. We're going to try and deal with two quite complex topics. One is health systems resilience, and the experience over the last 3 years, I don't need to tell you, has really challenged our health systems, even if we thought they were resilient before. So that is a really important discussion that we need to have. But we are also looking to layer on top of that what it means to ensure that they are not only resilient, but also equitable. And we have a lovely panel of speakers to introduce that particular topic, and I will come to them later. But I do want to start off with some comments from our WHO Deputy Director General, who is an apology. She is not able to be here in person, but she has sent us some remarks from where she currently is in Manila. So please, if we can have the comments from Dr. Susanna Jakob.
Dear colleagues and friends, greetings from Manila. I am sorry that I am unable to join you in person in Berlin. I congratulate the World Health Summit and WHO teams on organizing this year's World Health Summit. I also thank the organizers for choosing health systems resilience and equity to stabilize societies, economies, and governments. It has been a powerful demonstration that when health is at risk, everything is at risk, and that there is no global security without building resilience in countries' local health systems, of course, with global solidarity, cooperation, and mutual confidence. The pandemic by the most vulnerable. This is why the task of supporting countries to progress towards universal health coverage, based on a foundation of primary health care with essential public health functions, is more urgent than ever. Universal health coverage and health security are interdependent. We cannot achieve one without the other. Resilient health systems, built on robust primary health care, are a vital first line of defense against outbreaks with epidemic and pandemic potential. In practice, this means a health system that has earned the trust of the communities it serves, is well prepared, well resourced, and flexible enough to absorb the impact of disrupted events and maintain safe health services. To inform recovery and the Building Back Better agenda, WHO launched its Health Systems Resilience Position Paper in October last year. It articulates WHO's vision with 7 policy recommendations for the recovery of the health sector as central to socioeconomic recovery and development. This vision is based on the premise of primary health care and its essential public health functions as the bedrock of universal health coverage. It is informed by the lessons learned from COVID-19 and other events, and recognizing the need for improving equity across the social and environmental challenges and determinants of health. WHO's position paper spells out each of these policy recommendations in more detail, with actions for each. My hope is that all member states and partners read it, implement it, and reap its benefits. Every crisis presents an opportunity. Although the pandemic has taken so much from us, it's also giving us the opportunity to write a new future that is healthier, safer, and fair, but an investment to be nurtured. It is not a luxury, but the foundation of social, economic, and political stability. Now is our chance to build resilient, equitable health systems. Let us not lose it. I thank you all and wish you all a fruitful discussion.
Perfect. Thank you very much, Dr. Jacob, for those opening remarks for this session. Now, the session is going to be divided into three broad sections. We will have initially three of our, well, Dr. Jacob has done hers, so another two of the presenters who will give us a bit of an overview to set the scene for the discussions. We will then have a middle section that will ground equity and resilience in the realities of country settings. And then we will have a final section that is about ways forward and what equitable and resilient systems look like if we imagine them for the future. We will try and have a conversation across the panelists and with you. In between, we have Miriam here, who will have a roving mic for your questions. And we'll try and make this as lively and discursive as possible. So I would now like to call our panelists onto the podium, starting with Francesca Colombo, who is with OECD, the head of the Health Division. Round of applause, please. Marcos Espinal from PAHO, the Pan American Health Organization. Anisha Foster from Pfizer, from the Product Access Global Health and Social Impact, Vice President. Hussein Ganati from the Tehran University of Medical Sciences, the Chancellor. Kolinda Grava Kitarovic, the former President of Croatia. And last, but certainly not least, Juan Pablo Uribe from the World Bank. Thank you very much. Just let me know if you're on the podium or if you're comfortable doing your presentations, your interventions seating. So to start off, Marcos, can you please outline some core considerations on equity and health systems resilience from the perspective of PAHO?
Thank you. Good morning, everyone. Obviously, we've been hearing throughout these 3 days, wonderful 3 days with so many young people around that make me feel energetic again, about universal health and resiliency. And it is clear that universal health cooperation and access to health, which is another important piece, are the foundations of resilient public health systems. But those health systems, in order to be resilient, they need to be able to adapt, transform, and also face crisis. It is not a system that only addresses a COVID-19 pandemic, but then forget the other daily routine works like managing NCDs, managing NTDs, HIV, TB, and so on. So it has to be adaptable and able to manage the crises, but also to continue doing the daily health services people need. But how do we come up with, how do we measure universal health? Because we keep talking about UHC, we keep talking about access to health. But in order for us to ensure that those health systems, which are, needs to be based in primary healthcare approaches, are able to manage, we need to dig in order to unmask the devil. Because I think the issue of combining health equity with resiliency or resilient health systems, it's in the details. If we look at the Americas, in the past 20 years, there are some indicators that suggest that there were progress to achieve universal health, universal access to health. For instance, the UHC Service Coverage Index, which is a very important index that it's the one that tells us about SDG target 3.81. It's a composite index based on 14 trace indicators, indicators that represent infectious diseases, non-communicable diseases, service delivery, and this index is very telling in the Americas. From the year 2000, the index was based 66 point. It's a unitless, based 1 to 100. 66 in the year 2000. In the year 2019, that index increased to 77, meaning that the region was making progress to universal access to health and universal health coverage. But that progress was not equal in terms of the people living in the Americas. If we look at reproductive, maternal, mother, newborn and child health services, there is another index there that shows how inequalities are affecting the lowest and the poorest, the lowest in the income quintile. There were progress also in the last 20 years, but that progress was 80% access to those in the highest income quintile, and only 70% or less those in the poorest quintile. So meaning, do we want it to combine equity with health systems, the resiliency, then we need to make sure we address those in the lowest quintile, those people living in situation of vulnerability. Let me tell you something. The Americas is probably the highest region in terms of inequities. A lot of indigenous groups, women, Afro-descendants, prisoners, people living in situation of vulnerability. And why is the highest in terms of inequalities? Because it's a middle income region. We only have 1 or 2 low income countries. So how come countries that are growing economically, countries that are getting wealth, are not distributing equitable the gains to their people? And that's the main problem in the Americas. A lot of money, but not well distributed. If we look at data from 17 countries showing that unmet care needs were massively higher in the lowest or the poorest groups in the region. And these were basically problems with systemic deficiencies, structural deficiencies, and certainly tell us that, again, getting into the equality issue to make sure they receive the benefits of the health system, we need to to make sure those living in situations of vulnerability are given the benefits of the health systems. Let me tell you, the other thing is that out-of-pocket expenses, you know, it's been declining. Families that really are spending more than 10% of their own household budget into health systems, into their healthcare, this has been declining in the Americas. But again, the families that in the poorest quintile and families with people aged 60 or more are the ones having the hardest financial hardship in terms of healthcare needs. And having said this, it is true, you know, we were making progress to universal health coverage and universal access to health, but then the pandemic came and reversed everything. We went backwards several years into poverty, and Juan Pablo is here, who was Minister of Health of Colombia before, and he was able to leave that. We went backwards, and everything went back. The systemic problems were shown more and more. Again, the poorest and those groups living in situation of vulnerability were the one mostly suffering. But at the same time, our ministers of health, our countries, came out with innovative approaches to ensure that they could address those issues and put at the center of the situation those poorest group. Like, for instance, Peru looking at converting the Pan American Villa for the Pan American Games into a 3,000 hospital. Argentina reducing taxes or prohibiting exporting oxygens and things like that so the people benefit. I think it's important to say that those innovations were also paired with innovations looking at the regional office, and I'm going to be finishing in a minute. In PAHO, we have a policy that was issued in 2021 about building resilience health systems based on primary public health approaches, primary care approaches, but also post-COVID recovery. Ensure that we protect the games and that we look forward to it. And for that, we have several tools also. The strategic fund of PAHO, which is 20 years, you know, and helping a lot of our countries buy medicines and technologies. The revolving fund for vaccines, 41 years, providing vaccines to our countries. And my colleague, James Fitzgerald, who is sitting in the audience, is going to talk later in another tool that will help to reduce inequalities and address making sure our systems are more equal, which is the new platform PAHO just launched on technology transfer and making sure we are able to manufacture vaccines in the region, because the region cannot live out of dependence. And that's another issue. I'll pause here. Thank you.
Great. Thank you very much for. I think the two particular points that, if we have time, I'd like to double back on is you had raised the issue of that there is money, but it is not well distributed. And that is a critical issue around the question of equity that is not particularly well addressed, particularly in the discussions within low and middle income countries, what that means in terms of the redistribution. And I think you illustrated really quite powerfully that if a system is resilient, it should have been able to better withstand the knocks that we've had, and the strategies that we need to adopt to change that. Juan Pablo, if I can come to you from the World Bank's perspective as well, can you give us your views on the topic?
Can I speak from there?
You can.
So, good morning, and thanks so much. I prefer to speak from here. I'm very happy to be here. So thanks for the invitation, and my regards to everybody in the audience and here in the podium as well. Look, first thing I want to say is that we understand health systems resilience and equity as two terms that in a way are embedded both ways. It's not one or the other. They're not, to a certain extent, different. Of course, they have important implications in themselves, but they're fully connected. I want to start with that. And I'm going to give practical examples to this and try to defend that thesis that when you have an environment with higher equity levels, you have a more resilient environment. And where there's more protuberant inequities, you have less resilient capacity. That's, let's say, the basic assumption I'm starting with. This may sound conceptual, and I'm going to go quickly into some conceptual aspects in it, but it's also very practical. And I hope that I will also be able in 5 minutes to go into some very high-level practical implications. I think both the conceptual and the practical discussions are important, but to be very frank, I think the practical implications are more important than the conceptual. The bank did throughout the last year, and I hope that very soon you will be able to go through it and to criticize it, a flagship report that as all reports has an exciting title. Let's see the content. And it's called Change Cannot Wait, Building Resilient Health Systems. And what our colleagues did was basically looking, Marcus, at a huge number of countries around all regions in the world as they confronted the pandemic, and seeing what they did and how they did it and what were the results that they achieved with their responses. Numerous countries. So basically learning from the country's response. The responses were very different, as you all know. But looking through them, you can identify some core competencies, some skills, some abilities that we could list as features or constitutional elements of resilience. Which ones were there? Number one, and I insist on that one because it has a very important practical implication for organizations like ours that are there to support countries and to improve their work with vulnerable communities. The first one is that resilient systems were those who were more integrated systems. So as health systems had higher fragmentation, or they were coming from a higher degree of fragmentation, their resilient capacity was lower. Their capacity to confront an additional burden, a shock, a stress was lower. So integration is critical, and I will just pose this question out there. Are our efforts contributing to integration, or on the other side, do they contribute to fragmentation? If it is the latter, and if this, let's say, analysis is correct, we are not helping to strengthen resilient health systems by disintegrating health systems. A second capacity is that of awareness, and it's being connected with communities. It's being able to listen to alerts, to see signals, to, again, be able to observe them and then to react. Awareness of risks. They need to be agile or fast in response. And I'm going to conclude in what is needed for an organization like a health system to be quick in responding. They should be absorptive of shocks. That means they have to have the capacity to again, support some stress and confront it. They need to be adaptive in the sense of minimizing distortions. And finally, and very important, they need to learn from what they're doing, from their mistakes, from their successes. Many of these attributes may sound, again, conceptual, but when you're looking at the functioning of a health system, there's a lot of practical functions, of practical responses and day-to-day work that can represent each one of these competencies. By the way, a lot of this sounds like Juan Paulo is talking about an organism. Juan Paulo is talking about an individual. Juan Paulo is talking about a team. or an institution. And it's exactly that. Systems, health systems, are very similar to all those other characters that I just described and must be able to display those competencies and skills. Before moving ahead very quickly, the learning plus all this flexibility is fundamental because we don't know the phase of the next pandemic. We project things from what we know. We're not able to project things from our ignorance. But the next pandemic can take many different phases, and it may probe the system in many different ways. Everybody's talking about vaccines. What if the next pandemic cannot be addressed with vaccines? So keep these competencies as our learning capacities to be better organisms. And again, to be able to support the uncertainty with a better range of responses and hopefully of successes. Quickly, for us in this resilient health system study, PPR, pandemic prevention, preparedness, and response, is an integral part of resilient health systems, of course, and I think it's obvious from the above statements. And PPR and resilience find themselves in the corner called primary health care. In that corner of those two streets, you find PPR and resilience together. By the way, it's in that corner where the construction of what we have, of what we call universal health coverage, takes also place. So keep in mind, please, PHC as that cornerstone of this construction. Equity enhances resilience, as I said it in the beginning. Countries, Marcos, the countries that were more integrated, less unequal, with less exposure of vulnerable communities, with less exclusion of communities by any sort of discrimination capacity. Those countries that were more equitable did better. And you can see also the concentration of morbidity and mortality precisely in expressions of inequity, with many different phases as well. But again, looking quickly through countries, you would see a very high correlation between equity, universal health coverage, resilience, and a better result overall in the response to this challenge. Of course, access to services, and therefore reducing obstacles in access to services. And the most important one, as Marco said, is the out-of-pocket payments is fundamental in the early stages of an individual facing or a community facing a pandemic. And the same happens with community engagement, where you have universal health coverage. When you have a much more equitable environment, the engagement is much more easy, much more forefront, much more sincere. And this is a key aspect in responding to a pandemic. Final comments, just to conclude. Practical, and this is difficult, but resilience in health systems and universal health coverage can only be achieved through capacity building within health systems. It needs that capacity building. It needs an equity lens. It needs governance and leadership. And finally, it also needs and starts with political determination. Thank you.
That was excellent. Thank you very much. A critical point there, the learning health system. I think that the politest version of this that I can say is that repeating the same thing and expecting a different outcome is futile. Thank you very much for that. We have a few minutes for if there are any points of clarification or points that you'd like to raise over these first two. Any questions? Yes, please. Can you please just say your name and where you're from?
Thank you very much. My name is Olya. I'm with Frontline AIDS, and I'm also an alternate for one of the civil society seats on World Bank fifth PPPR. Thank you very much for this discussion, and many apologies if I'm jumping the gun and raising this point. But what strikes me as I sit here is that we talk about community systems in quite a kind of maybe passive way. And a core part of my work is supporting governments through partners with whom we work to really streamline and put more emphasis on community responses for health, or so-called community systems. And I think just to say, I would really appreciate kind of more focus on this point in this discussion, because from our experience, these are really the systems that address very effectively inequities, resilience, and they really provide a multifaceted added value on service delivery, advocacy, strengthening governance. And I want to share that as civil society constituency, we're really excited that language on health and community systems is now in World Bank PPPR founding documents. And we really look forward to proposals from governments that would really address issues related to community systems within pandemic preparedness. Thank you very much.
Thank you. That's, can we hold that? We will keep the community engagement because I believe Nisha is also going to be talking about that a little bit, but we will have a block at the end for discussions. I'll take two more and then we'll move to the next section.
I'll be quick. Göran Thomson, Karolinska Institutet. Juan Pablo, you talked about the need for political determination. I think what COVID-19 showed was a lack of functioning governance at all levels. So, the political determinants of health. If you could do one thing to improve the situation, handling the political determinants of health, what would that be? Sorry for that question, but please try to reply.
Thanks. That's an easy question. Do you want to?
Let's take the following one.
Okay. And we'll take just one more from there and hold it for the next round, please.
Hi, Samantha Rick from AVAC. I just wanted to point out the way that we've been talking about pandemics the last 3 days. I mean, Juan Pablo mentioned some pandemics can be solved by vaccines. We have a pandemic that can't be solved by vaccines. It's been running for 40 years. It's HIV/AIDS.
You're sorry.
Yeah, please.
We have a pandemic that hasn't been solved by vaccines. It's HIV/AIDS. It's been running for 40 years. And we don't seem to have learned a lot of lessons from that. We're talking about solving future pandemics. What can we do? We need more fund, more resource mobilization. What about ending the pandemics that we have now? And I also just want to point out, not every country had a governance problem with COVID. Many countries in Africa and Southeast Asia did a fantastic job with it. Other countries in the global north are the ones that had political problems. So making sure we don't talk about we all failed, we all did this, not all of them. Thank you.
Thank you very much. Do you want to 1 minute or less?
Right.
Please.
Okay, I'll start with political determination. I will invest more. In the Americas, public investment in health in 2010 was 2.8% in the region of the Americas out of the GDP. In 2019, it's 3.9%. And the recommended threshold is 6%. If we invest more, we can address all angles of these inequalities and systemic deficiencies. That, for me, is the key issue, because education and health has been always neglected historically, and it's getting better and better now. Social protection is part of that also, but investment, it's key, and well invested. We don't talk here about corruption and things like that. Well invested. Thank you.
Thank you.
So very quickly, first, I'm very happy to have the participation of civil society as board members of the PPR5. By the way, I hope everybody takes that PPR5 as a collective endeavor, not as a World Bank endeavor. So it should be all of us PPR5 and not the World Bank PPR5. Minor statement from my side, because again, it should be an instrument that serves everybody, and it should be an instrument where everybody can bring in value to make it effective and successful. So thanks so much. I could stay the whole day talking about communities. I think communities are basically the central element of primary health care. By the way, we've been talking a lot about community health workforce in these last days. And I think that's a great emphasis in the upcoming agenda. We should do it. And with that, the community systems concept, etc. But again, let me emphasize that without community engagement, which also comes in more equitable environments, you will not build resilient health systems. Without that, you won't be able to do. And again, the connection with communities has a practical implication in the effectiveness of confronting an outbreak or a pandemic. So fully aligned on that. And finally, on the political decision-making and ownership of health, Goran, I believe that we all need to change in our countries the concept of the health system being an expense, a cost, a recurrent cost, and an increasing recurrent cost. It should be an investment in human capital, an investment in human capital with an incredible political return, by the way, for the politicians. I think that's the whole narrative that needs to change. When politicians find that there's credit for the effort that they invest in the health sector, they will always defend it. And we need to make that easier by, again, showing how health systems respond, contribute to form human capital, and bring dividends to society through an investment, not through an expenditure. And I've seen how political leaders, when they understand that, they are the best defenders of stronger and more resilient health systems.
Fantastic. Thank you very much. Francesca, can you give us a bit of a grounding from OECD's perspective?
Thank you. I'll also come here, take the opportunity. Thank you so much. So I will articulate my talk in three main areas. The first is a little bit on the concept, but I'll be very brief. I think we heard so much and so eloquently from the previous two speakers. Then a little bit of the evidence, and then thirdly, maybe some possible policy levers as well. So in terms of the concepts, yesterday I was in all sorts of sessions where we talked a lot about pandemic preparedness and response and universal health coverage. And it was all talking about two sides of the same coins. And I would say that if we are talking about resilience and equity, again, we're talking about two sides of the same coin. Those are both important objectives of health systems, but they are incredibly interlinked between each other. Because obviously you can have a health system which is not resilient, so not able to withstand a shock, to absorb it and to recover from it. And the consequences of not having a resilient health system is what we have seen. It's very inequitable outcomes and an impact which is much higher on vulnerable populations. At the same time, a health system which is inequitable to start with will mean that there will be a lot of population vulnerabilities which are inherent in that health system. And in the moment in which there is a shock, the shock will be magnified by those vulnerabilities. So, you know, this is just to explain that really we're talking about two mutually reinforcing goals of health systems, not addressing which will have mutually detrimental and reinforcing and magnifying also consequences. Now, if we look a little bit at the reality, and of course I speak from OECD, which is really the high and the number of middle income countries, but just to take a look, obviously, I probably don't need to say it much. We know that the toll of the pandemic has been huge on human life. But if we look even within this group of countries, OECD countries, there is up to a 50-fold differences in excess mortalities between the countries that were the hardest hits and those who were the least hit. So if we take the country like Mexico and Colombia, they have 55 higher degrees of excess mortality relative to countries like Norway and New Zealand. And that obviously is linked to many, many different issues, the underpinning inequalities in societies, the speed of response, the political leadership, the capacities, and so forth. We can go into that. I mean, but excess mortality is just only one element, of course, even if we look at issues like now, you know, when a number of countries are dealing with the recovery phase, I think somehow we don't put much attention to the recovery and how health systems are struggling really to reduce inequities in the recovery. We know that up to 25% of people linked who had COVID live with long-term consequences, including long COVID, and those are very unequally distributed as well. So that's the first issues, inequities within countries, but then across countries. But there is then the other issues of the inequities within countries that have been very much alluded to by the previous speakers. But just two illustrating facts. First of all, the burden has been very much falling on those that require chronic care. If look again at the OECD countries, 92% of the deaths from COVID-19 were among those aged 60 and over. And those were people that are much more likely to have multiple chronic conditions or more than one chronic conditions. And in fact, those are, more than 50% of these populations live with at least one chronic conditions. Again, huge differences because people who have chronic conditions themselves are usually among population groups which are more vulnerable, who are poorer and so forth. So again, this reinforcing path, but I think it's useful to put it in perspective that those who were really very much affected were those requiring chronic care. And they, in a way, had a double burden from the COVID-19 pandemic. First, there are disruptions in the routine care. These are population groups that rely very much on routine care to make sure that they can have, good outcomes. But secondly, there are also those who are at higher risk of dying from COVID-19 because they have those underlying chronic conditions that increase their vulnerabilities to COVID. But there is obviously another dimensions of inequalities, which is how COVID-19 has highlighted widespread inequalities. And if we look at no matter what marker, if you want, of inequalities or of vulnerability that you choose from, you will see that those people who are vulnerable will have had a higher chance of dying. So no matter whether you take deprivation, whether you take income, whether you take ethnicity, whether you take migration status. We have looked at some data for OECD countries. And for example, if we look at people with low income countries, they had between 1.4 and 1.8 higher chances of dying for COVID-19. Those who have a foreign-born status, so they're foreign-born populations, they have up to 2.2 fold chance of dying from COVID-19. And those who are from Black and Hispanic peoples, are up to 3-fold more chances of dying. So in a way, it's what we see that disadvantaged group have a higher likelihood on the one hand to be in contact and having more exposed to COVID-19 by virtue of their working most often as frontline jobs, but also by having to perhaps commute in very cramped, commuting or even in housing, or even in terms of the job that they have. So they have higher exposure to COVID-19. And at the same time, they're also less likely to be in good health and more likely to have risk factors, including things like overweight and obesity. And that has created their higher vulnerabilities. So on the one hand, they live in housing, in jobs, in working conditions that make them more vulnerable, and they are also more vulnerable because of those particular higher health risk factors and groups. So we are in a way in a situation in which health inequalities and inequities in access and in health pre-existed COVID-19, but COVID-19 really had a magnifying glass and put a magnifying glass onto those. Now, from that, and I think there are ample evidence which is really popping up about those inequities and inequalities. So what do we need to do? There is a clear need for a very focused policy attention to deliver not just resilience, but both equity and resilience. And it implies many, many different actions, but I would like to highlight 6 in particular. First of all, it's really prevention. Public health is key. I mean, this is something that we've been saying for I don't know how long a time, but it's even in OECD countries, only 3% of total health spending it's devoted to public health and to preventions. So healthcare spending is much more overwhelmingly put towards curative care and not preventions. And this clearly leaves too great a share of the populations with underlying conditions that make them more vulnerable to COVID-19. So that's the first really absolute thing. But linked to that, there is also the issues of the wider determinants of health. So, you know, the social gradient that we have seen in the death in COVID-19 really illustrate policy failures in terms of addressing those social determinants of health. And those go outside the health sector. Lifestyle, of course, poverty, even stress, unemployment. In a way, we cannot build resilient health system if we don't address those wider issues which are outside the health system. Another policy lever, which I think is important, is to develop and expand primary health care and community care. It was very much alluded to into the previous session. But if we look at primary healthcare, it's the part of the health system which is least inequitable and most contribute obviously to addressing inequalities. And still we devote less than 15% of total health spending to primary healthcare. So there is a need to invest in primary healthcare to make sure that we can address and reduce those vulnerabilities. Not only, this is a part of the system which has more trust of the population and the communities. So, I mean, again, it was said, but I think it's important to reiterate it. Third issues, I think we critically lack information. We have lot of data. Actually, health systems are awash with data, but we critically lacked disaggregated information on key dimensions of disadvantage, deprivations, ethnicity, ethnic group, even location in areas of where deprivation is higher. I think we need to also critically support health and digital literacy among the disadvantaged. We've seen escalation of use of digital technologies and tools through COVID-19, but it's really those who are better educated with higher income, which are much more able to use telemedicine or even to, protect themselves from misinformation. So this is another levers which I think it's particularly important. There is the importance of also ensuring equitable coverage of COVID-19 tools, lots which has been said about that, and that's both within and across countries. And I think, more generally, there is an issue to invest much more in health system. And we have made some heroic estimates, I think, at the OECD of the extra investments which are needed to have much more resilience and equitable health system. We came up with a figure of 1.4% of GDP additional injections into health system. This is based on real data. So it looks really at where countries are investing right now in all the different parts of the health systems. And the majority of the health spending is actually needed to go to train and also retain more health professionals, which are fundamental, particularly in primary healthcare, which are fundamental to equity and resilience. Thank you.
Thank you very much, Francesca. It's always great to actually have real hardcore data as well to reinforce the discussion. The next speaker we have is Hossein Ghanati, perspective from Tehran.
Morning, thank you. Today I'm going to share with you the experience of Iran to enhance health system resilience in addressing health equity with some reflection on the recent COVID-19. Evidence shows that critical challenges to sustainable development, which may jeopardize effort to be healthy, sustainable, and equitable society is adopting innovation, timely and contextually tailored measures. For instance, but not limited to collaboration with non-state actors including this civil society and public. May I have my slide, please? And the public representative are crucial to address the challenges to achieve equitable and sustainable health system. Next, please. There are some systematic inequity which impact individualized life. For example, food insecurity, unemployment, housing instability, homeless, domestic violences, and etc. The pandemic demonstrates that communities who suffer most from the chronic structure inequality and lack of equitable access to water, sanitation, quality life environment, and quality education were more likely to collapse in face of the acute crisis. The COVID-19 situation was exacerbated in this society with unequal health, social, and economical condition. The pandemic impoverished millions of people, particularly women and low-skilled workers, lost a disproportionate share of their job. Also, the crisis showed disruption of education, exacerbate gender inequality, and jeopardize food insecurity, particularly among poor people. While health system overburden led to reduced routine service, particularly for the poor people. Next, please. In my university, as you see here, there was a 6 billion block offered by the WHO, for example, service delivery and etc. And my colleagues add 2 block to it: meaningful intersector collaboration and surveillance and response system. Next, please. As you know, we have double burden of problem, COVID-19 and sanction, and really was so difficult time for us, as you see here in this comment. Let's please. The PHC pandemic plan in Iran was as follows: providing health care services in person and remotely, early COVID case identification and contact tracking, family or workplaces, complying with isolation and quarantine routine, rules, hotel and residential quarantine, and outpatient COVID-19 therapeutic improvement, and general vaccination based on national guidelines. Next, please. I'm head of the Chancellor of Tehran University of Medical Sciences, the biggest university and oldest in the country. I'm not just responsible for education and research. In my country, the medical universities are responsible for some part of the country. I'm responsible, my university is responsible for 4 million people, near 4 million people in south and center of Tehran, and most of them are poor because the south of Tehran is poor area, including 500,000 Afghan refugees that live in this area. And we changed the method of the management. As you see, we added some units, some extra works to cover the COVID-19 in the health system that we have managing. Next, please. You see here, we started the vaccination coverage, and we have a mobile machine to go to the poor area, and next, please, and cover the Afghan people. We covered 100% people of the university territory, and also covered most of the Afghan people, and also give them some services that was so difficult to give them. For example, mobile dental care we send and give them these kind of services. Next, please. And also we talk with the different NGO, for example, clergy, and change the mosque and holy shrine to places that, for example, you see here, cover holy shrine to make mosque production facility and other thing. And also people came and make some facilities for the remote education and online education, for example, tablet to the people. Addressing to the mental health sequences, we have a lot of PTSD in different kind of the university territory. This is the District 17 in Tehran, with 300,000 people. As you see here, we have 4,000 deaths in this area. And we give them, by help of the NGO, full coverage of the mental services. And next, please. In conclusion, this COVID-19 crisis was an exercise for my country's health. And we learned the whole of the government and whole of the society together can make better situation for these three items: universal preparedness, universal solidarity, and universal health coverage. Thank you very much for your time.
Thank you very much. I think the really important for us to consider, particularly within the context of resilient health systems, that we also in many contexts are talking about mobile populations that don't have a strong basis, as well as the fragile setting that doesn't have the infrastructure and bases that we know health systems are supposed to have. Really powerful illustration. Thank you very much for that. And we have another country and global set of cases from Kolinda and Croatia. Thank you.
Thank you. Good morning, everyone. My experience, my profile is a little bit different from the rest of the members, my colleagues on the panel. So I will use my professional and personal experience in government institutions, both national and international, in security and in geopolitics, in order to combine these experiences and to give some reflections on lessons learned and some recommendations through three sets of experiences in Croatia, in Africa, and with respect to universal health coverage, weaving together the 7 WHO policy recommendations on building resilient health systems, not necessarily in the order that they were presented. So let me first start with Croatia. Croatia has universal health coverage, and we have achieved a relative equity when it comes to access to health, and in particular, the rights of the patients to procedures and to treatment. However, during the pandemic, our mortality rate was relatively high, unfortunately, one of the highest in Europe. So there are very particular reasons for that. And one of the most important being redistribution of resources, financial and others, because when it comes to health equity, the inequity that we experience is the access to healthcare based on the region of Croatia where you live. So building better and stronger facilities and providing for telemedicine is certainly one of the ways forward. We need to invest more into infrastructure. We need to invest more into training, education, lifelong education of healthcare workers, but also into education and information of the general public. And one of the aspects during the pandemic that bothered me most was the way that media presented in the initial phases of the pandemic. First, the access to vaccination and the lack of the security of the supply chain, but also that referred to the cost of some of the medicines, which reflected onto the decisions of medical workers to deny some patients the medication in fear of being accused of preferential treatment or anything like that. So my question was always, what is the cost of a human life? And we need to do everything in our power to help any patient. Furthermore, during the pandemic, we experienced a combined shock, sort of a multiple hazard situation when early in the pandemic in March of 2020, an earthquake hit Zagreb, which is about 1/4 of Croatia's population. It was a strong earthquake that caused damage to the hospitals. So people needed immediate evacuation. We needed redistribution of resources. And with the already restricted facilities that we had and services due to the pandemic, the situation was even worse. However, what was positive was the reaction of the local community. Immediately, volunteers, including football fans, they jumped to the situation to aid, and they were literally transferring patients from one hospital to another. They were helping women who were giving birth in the parking lots, literally at the time. So this goes to show that all hazard emergency preparedness has to include everyone, not just medical facilities, and focusing on the staff and the facilities and the competences themselves, but also external input and engagement of local communities, not just government and local government, but really NGOs to every single citizen. The next aspect that I want to talk about is my experience with Africa. As women political leaders, a global ambassador for vaccination, I was trying to boost vaccination, not just for COVID, but other vaccine preventable diseases in Africa. And what we have encountered, of course, is the problem with facilities, primary care, the last mile capacities and capabilities for vaccination. But also one of the biggest sources of frustration was the disconnect between those who can and should deliver a vaccination and healthcare, and those who should be on the receiving end of that spectrum. And in all of that, unfortunately, we witness a lot of a lack of solidarity. We witness vaccine inequality, even vaccine nationalism, and that even prolonged or made deeper the rift between developed countries and countries in development. And also, in my perspective, we've also seen weaponization of vaccine as we see weaponization of health services and healthcare facilities as part of the geopolitical divides and what we see in the international arena. Segregation and lack of access, cultural and religious restrictions were also a big problem. Now, the third aspect is universal health coverage. When the pandemic started, I was in the United States and I decided to return to Croatia simply because Croatia has universal health coverage, and I said relative equity of access to healthcare. And in those circumstances, when it was still unpredictable how the pandemic would go, of course, all of us wanted security. And because of that security, I decided to return to Croatia, and having in mind the discussions that we used to have in the context of a university that I was at for a while in the United States, where about a third of the students were from Europe. We basically had universal health coverage, and the rest Americans. And we could not simply understand the deliberations that it's every individual's right to choose whether they're going to pay for healthcare and whether they're going to pay higher taxes because of universal healthcare. So there is a lot of mental situation or blockage, misinterpretation out there that needs to be overcome. Now, looking at the world ahead of us, we're going to continue to be facing pervasive instability, rising strategic competition, recurring strategic shock and disruptions. And to close and to transfer to the last element of this panel, I just want to give a few recommendations. First, we have to identify and mitigate strategic vulnerabilities and dependencies in each of our systems and globally. Second, we need to prepare for, resist, respond to, and quickly recover from strategic shocks and disruptions, which means that we need to strengthen prevention, preparedness, response plans, build surge capacities, and ensure for continued preventive and chronic disease management care, which will certainly be affected by it. And the final recommendation and conclusion, which comes from my personal experience, When you look at the issue of universal healthcare, but at laws and bylaws and everything, the legal system within the healthcare, one has to keep in mind that there are people in government who want to be leaders and think of future generations, and those who want to be or are politicians and think of future elections. And therefore, they will act based upon what the public wants or what the polling shows. During the pandemic, health was one of the primary issues, but now it's been pushed down that priority agenda. So we need to do as the whole of the society to put pressure and put more emphasis on healthcare so that it becomes a lot more important in the context of what polling numbers show. And that in turn will certainly affect also those who look at that situation of their personal benefits in order to be able to look beyond personal interest and look at the whole of society and the public interest. Thank you.
Thank you very much. I think the wonderful thing about the panelists that we have in the last set of presentations is really getting a sense of just how complex these areas are. In a 10-minute, sorry, short presentations, 10-minute or less narrative, that really shows how important it is that we understand that we're trying to make all of these decisions and provide all of this support in a really complex political, environmental, with earthquakes, all of these things together. And we have to be agile, again, borrowing a term that has just been used here, in trying to bring this together. Now, before we do the final section, which is on ways forward, I will take two quick questions. Can I take, yes, I'll take yours first. From the audience. There's one at the back. I'll hold yours for the final discussion.
Hi, my name is Mike Podmore.
You mind standing, please?
Sure. Mike Podmore from Stop AIDS based in the UK. This is a broad point really for all the panelists and for all of us here. I'm disappointed that this is the only session at the World Health Summit that has equity in the title. In this session, the only session that does have equity in the title, there's unfortunately no one on the panel from the most vulnerable or marginalized communities. I would respectfully challenge the organizers and all the panelists and all of us here that we can't effectively address equity or understand what inequity looks like if we don't platform and hear the voices of and the needs of those who have least access to or experience of quality healthcare services. Please can all the panelists share how their organizations and they personally are working to ensure that they are listening to, collaborating with, and holding themselves accountable to the poorest and most marginalized to ensure that they are not just leaving no one behind, but actually putting the last first in their policy and programming. Thanks.
Awesome, thank you.
Thank you very much for this opportunity. I'm Dr. Lomo, the Deputy Minister of Health in South Africa. The last speaker really crowned it all for me when she says, please be consistent on issues of health agendas, even post-COVID, so that it does not take the back burner again. I'm really impressed. But my question would be to the first speaker. I would have probably preferred to say the pandemic delayed our focus on universal health coverage than to say it reversed it, because it's a choice to have it reversed. But my request, this comes very strongly to the countries in the West, that forever we train healthcare professionals in the South, and they prefer to choose to go to the West. And for in my country, out of 10 medical schools, you would find that there's about 60% of students who complete and move to Canada, Australia, US, and everywhere else, and we have no way to get them back. Now, morally, I would have thought that maybe the West would then say, how much do you really need to fund those possible? In any way, we'll always be coming to those countries, and we will always be training and say, in terms of health workforce, how do we build that capacity. I can tell you without fear of contradicting myself, in universities in our country where we have selectively gone to the rural areas to pick those students to train as medical doctors and nurses, those are the ones who remain. But those who come from the affluent communities who never know how it is to have a mother who actually delivers without an assistant nurse, those are the ones who leave the country and go elsewhere. Now, the universal health coverage must also talk to equity of health workforce, and we would need some guidance and some support from the WHO. What is WHO saying about South always training for the West, and we never, and even for the North, and we never get any support in terms of financial support in that regard. Thank you very much.
Fantastic. Thank you very much. So we have both comments addressing the people-centeredness of health systems. One about the making sure that we bring the right communities and provide the opportunities to amplify their voices, and about the workforce. If I can, we'll double back to that at the end, because I really would like us to listen to Nisha and the final comments on the way forward and the role of the private sector in the way forward. Thank you.
Thank you so much for having me here today, and thank you for engaging comments by all the panelists. I've been asked today to talk about a few things. One is the private sector's role in the imagined future, equitable and resilient health system. I've been asked to talk about the intersection of how public, private, and governments might work together, and I have an example of how we're doing that currently at Pfizer. And then also about my own reflections and on the pandemic and what it tells us about equity. And I think what you've heard from everyone here today is what it's told us is that we have a lot to do, but the opportunity is ours, and we must be intentional about what we do. And not only what we do, but who does it, right? We heard a lot about political determinants of health, social determinants of health, but without the voice of the marginalized communities, we'll have the same conversation in 5 years, in 10 years, in 20 years. And I don't think there's anyone in this room who wants that. Pfizer's core competency is quite clear. We discover, develop, and bring to market innovative medicines. And our intention is to make sure those medicines get to the people who need them the most. And so we saw the pandemic really just highlighted what we already knew, that we have to have those voices in the room to help us figure out how to overcome the barriers to access to care. And so one way that I know the private sector can be helpful, and I have the great fortune of leading what we call at Pfizer, the Multicultural Health Equity Collective. And it's not something that we put together during the pandemic. It's actually been in place since 2004. And so what it is a collection of external organizations, they're community-based organizations that are focused on the underserved. So you've heard a lot about the underserved communities, and if not for opportunities in education, I don't know how I would have fared in the pandemic, quite honestly. But we work with these organizations that are focused on African Americans, Latino, LGBTQ+, disabled, Native Americans, and others. And way before the pandemic, we talked to them about what we need to be doing differently and how we can help their communities and the communities that they serve. So it's always bi-directional. One of our main focuses with this organization was on clinical trial diversity. I talked about what we do as far as discovering medicines. And what they told us was that some people in our communities never hear about clinical trials. Their doctors never tell them it's an option. Pfizer, what can you do to help us there? They told us when they go to these clinical trial sites, there's no one who looks like them. Pfizer, how can you help us make sure that we're training up people in order to participate, to feel comfortable to participate in clinical trials? And so we listened to them quite often in different sections, and they thought that we were trusted partners. So when the pandemic finally did hit, all I had to do was send an email to some of these 40 organizations that we worked with over the years and say, we need you at the table. We need you to come tell us how our materials can be more culturally sensitive, how we can make sure that people in the communities know where to go if they want to be involved in the Pfizer-BioNTech clinical trial. And so we had great participation. One of my favorite organizations that we worked with is called Dia de la Mujer Latina, and they're focused on Spanish-speaking populations in the US, and really making sure that we combine the message, the mode, and the medium and how we communicate to communities. We were told many different things, from the images that we had on our materials to the language that we used. We were told that you're using a word, ensayo, that in some dialects in Spanish-speaking communities can mean you're going to be a guinea pig. That is not what we wanted to convey, obviously. And so we changed our language. We use clínicos estudios. My Spanish teacher will kill me. I probably didn't get my accent right, but we used different language to make sure that we were talking to them in a way that was inviting. We worked with local health workers to talk about the trial. We actually had one of our Spanish-speaking advisors go on the radio and talk about what it means to be in a clinical trial and why it was important for underserved communities. And what we saw after that talk was that there were 100 different people who in that area who called into the number that was the call to action at the end of that. So we are consistently demonstrating that the voices of those who we don't usually hear from are important. And if we listen and act on what we can within our own core competency, we can make a difference. And that's what it means to be intentional. For our COVID-19 clinical trial, we saw 30% of our US patients that are enrolled in the trial were from underserved communities. You don't see that in clinical trials because we are not as intentional as we can be, but this is one example. In the future, imagine resilient healthcare system. You have that equity, that person's voice at the table. And I alluded to a bit earlier what Pfizer's mission is, breakthroughs that change patients' lives. But you can't break through if there are barriers in the way. And so Pfizer is working alongside communities, as I just provided you examples of. We're working alongside governments and others in the healthcare ecosystem. One of the additional partnerships I want to talk to you about is one that we've had with Zipline. So way before the pandemic, Zipline, for those of you who may not know, is a company that focuses on autonomous on-demand delivery of essential medicines in hard-to-reach areas. So of course, 30 years ago, we could not have imagined a drone being programmed to land exactly where it needs to be to deliver blood, essential medicines, and vaccines, but we have that today. And our relationship with them, like I said, started in 2019. And long before we had emergency use authorization for any mRNA vaccine, we actually had Pfizer's scientists, manufacturers, and engineers working closely with Zipline to develop a soft box. And this is a box that could withstand dropping from a drone and also maintain the safety of mRNA medicines at 2 to 8 degrees Celsius. And we went into this and leveraged our talent from our people, not for Pfizer's medicine, but for all mRNA medicines that needed to be delivered in this way. And Pfizer and Zipline could not have been successful if not for the Ghanaian government. It is their decision what comes into the country. It was their decision to invest in making sure Zipline was successful. And since November, Zipline has been able to deliver nearly 750,000 doses of mRNA vaccines in Ghana in hard-to-reach places. So resilient health system starts with the government. It involves many different partners focused on a common goal. There are other examples that we can bring to bear, but I see I'm going to get the yank soon. But I just wanted to encourage us all to be intentional. It is not impossible. That future that we imagine can be realized if we are all focused on the same goal. Thank you.
Thank you very much, Nisha. We now have, sorry, just before I open it up again, that again, core running themes, building trust, the need to build trust, and that this is built over time. And we probably should be working on it before the next crisis hit. And I think the reality is that when we talk about health systems, it's not there and us. It is about all of us. We are all a part of the health system, and we all need to do our bit to contribute to the outcomes that we want for populations. So we have 10 minutes. I did flag to you that you will have a 1 minute at the end, 60 seconds or less, to say how you want to change the world to ensure that we have resilient and equitable health systems. So if you haven't prepared it before, start preparing now, and the clock will be running. But for now, yes, we had some starting right in front of me, and then the gentleman behind. I want to go then at the back, number 3, because often those at the back don't get an opportunity. 4 and then 5. I hope you saw that. If we can, you can keep the remarks short, please.
Thank you very much. I'm Dr. Milka Sokolovic from the European Public Health Alliance, and my question is about changing the world. So I hope I inspire good answers with that question. Let me start by saying that the COVID pandemic is not the only pandemic, and also not the only crisis that we face. We face the climate and environmental breakdown. We face the cost of living, energy, food security crisis, and they all drive inequalities to a catastrophic rate growth, and all spell hunger and poverty and ill health. Now, my point would be that wherever we scratch under the surface, thinking of all of these crises, we identify the same root cause, and that is that our economic and political systems are solely driven by profit. And what we need is a transformation such that our economic system is based on indices that actually measure the well-being of people and planet. So my question for you, and that of course requires political transformation such that the rich cannot buy the decisions they want. Okay, so thank you. So the question, I guess, to Francesca and Juan Pablo, but whoever wants to take it, is, do you see it happening? How do you see it happening? Thank you.
Thanks. And you need to build that response into your 60 seconds or less. The gentleman there.
Thank you very much. My name is Kenneth Prudencio. I'm the advocacy officer for CSO in Côte d'Ivoire. And we are working with health workers who were at the front line of the fight against AIDS, yes, and COVID-19. It was a big, we could see that there was solidarity, international solidarity to face this pandemic and to display the vaccine rollout. Instead of the, apart from this, it was also a bit a challenge for us in the civil society to explain to the communities why we didn't have enough vaccine for everyone when we had shortcuts, etc. So my question was about the fact that in African countries, for example, we don't have always the capacity, the structures to build, to manufacture, and to conserve drugs and vaccine. My question is, what is being done to ensure that African countries also have this capacity to be independent from international aid, to be independent when facing this kind of pandemics, knowing that for COVID-19, for example, Western countries were really, really hit by this disease. So we could understand what was happening on your side too, but AIDS, on what we can see and say, is that it should be also to build resilience in the countries, not only give aid, not only give vaccines. So this is my question. Thank you very much.
And then the gentleman way at the back.
Thank you very much. My name is Dr. Ohinaba Osudanso. I'm coming from Ghana, Chief Executive for the Comparative Teaching Hospital. And thank you for the opportunity. 2 quick questions. We've heard a lot today about how to really, leverage investments into health services. And I think Marcos, and somebody else indicated about the dwindling investment by governments into health care and especially into primary care. The big question is, what have we done wrong over the years? Because there is so much talk, so much discussion. Is it a question that those who are making the big decisions are not appreciating the outcomes of the investment that we are making? Because there's a lot of competing needs for the money of governments and globally. So what have we done wrong, or what are we doing wrong? Can the speakers tell us what are some of the strategies, the new strategies that can get politicians and governments to begin to look at it? ECOWAS has looked at about 10% or 15% ceiling. Now governments are even not doing up to 5% of investment in healthcare. The second question is to look at UAC, universal health coverage, and even health resilience as we are building it. What is the opportunities in education, basic education? Because building resilient health systems is not just about hospitals and structures and what have you. It's about also the quality of the population, the quality of the clients for healthcare, so that basic education can begin to leverage for us, populations of the world that understands health more deeply and better, for them to utilize the health services that are even coming up. Because in some places, even new health services are poorly utilized because the people, by way of culture or custom, what have you, are still reluctant to utilize new health services.
Thank you. I believe you're answering your question as you pose it.
Thank you very much.
Thank you, but you have raised issues on investment, lessons learned, and they'll be built into the responses. Sorry, the gentleman in the middle. Yes, yeah.
Thank you. My name is Matthias Richter-Turtur. I'm a professor of surgery in Munich in Germany. We speak about health challenges here. I have a question to Dr. Hussein Ganati, because this morning I could read in the newspaper that Iranian kamikaze drones are destroying houses in Ukraine used by Russians. What is your opinion? I think this is a really big health challenge. What is your opinion about these Iranian drones? Thank you.
Thank you very much. And one last question.
I'm not a politician. I'm just health service manager. I don't know, is it not responsibility to give answer to this question?
Can I take one more and then I'll come, you can respond as part of yours. We are running out of time. There was a lady on this side? No? In which case, can I come back to the panel then? Based on the issues that have been raised, we have less than 60 seconds each, but let me start with you, Marcos. Final
thank you.
Remarks.
Leadership, stewardship, and governance. That was the problem in the pandemic. If you remember a famous photo of Sky News that was around the world, lying dead bodies of indigenous communities in Manaus because they didn't have access. In the Americas, we have strong indigenous communities. And in order to address this issue, we need to use intercultural models that take into account the culture of those communities. The community issue is vital. Number two, the healthcare workers situation. This is a massive problem because they leave, because they are not well paid. Quality is a problem. We're joining forces now with the US in launching the Health Corp initiative to try to train our healthcare workers. The estimate is, as per WHO, that 600,000 healthcare workers will be in deficit in the Americas by 2030. And finally, there is no UHC for me, because UHC is a concept. It's coverage, but that doesn't mean it's measuring access. The key issue is There will be no UHC unless we solve the issue of those in the lowest quintile, the poorest community, and living in situation in vulnerability. When we equal those with those who receive most benefit, then we can talk about real universal health. Thank you.
Perfect. Thank you. Juan Pablo?
No, very quickly as well. No time to address the more profound questions, but I'm just optimistic that those questions are being raised. And as long as we raise them, hopefully we will find solutions to such big challenges. But I would say from my point of view, I see the complexity looking at all the interventions of these topics. But I do believe that overall we need more convergence and more collective effort, and we need less divisions and much less competition within health. I think we need to integrate ourselves much better. And I also think that we need to go beyond semantics and much more into actions at the community and country level. I do wish that future discussions will have much grounded, let's say, actionable elements in them.
Perfect. Thank you. I've been given the 1 minute thing as well. Francesca, please.
Okay, well, first of all, we cannot have resilient health system if we don't have resilient populations. And so going back, to your points, we have failed collectively to really, for all sorts of reasons, to address the social determinants of health and also the commercial determinants. So that's, for me, it's the starting point. On health system resilience, though, on the migration aspects and health professionals, absolutely. I mean, we need just to train more. High-income countries need to train more. And that's really, address both the push factors to migration, but also those pull factors as well.
Great. Thank you. Hussein?
Okay. I will tell my experience during the 40 years in my country. Self-belief of the people, education is the best thing that you can bring the people, as my friend said about the Africa, is the best thing. If you increase the understanding of the people about the situation, they come and help you. You cannot believe me. In the COVID-19 crisis, without help of the people, what catastrophic in the country. I must say something that really young generation also came and stayed in the hospital and died. But they continued as a people that defend from my country during the war, they came and help us. And I think the self-belief and education is the best thing.
Thank you very much. Linda?
Yes, thank you. To quickly address the very important issue of how you learn about inequity, you go and to talk directly to people on the ground who are affected by it. Second, on Africa, of course, vaccine distribution is just a short-term solution, short-term measure. What we need is build the proper infrastructure, not just for distribution, but for production of medicines, etc. And third, general conclusion on the global level, we definitely need more solidarity. We need more empathy. We need to realize that health is a human right and a public good. Thank you.
Thank you. And
sure, just 2 points. First is that if you are talking to the same people about these issues as you did last year, we're not doing it right. We have to bring in the voices of those who are most impacted. They have the solutions that work best for their communities, and we should be listening to them and helping to amplify what those solutions are. There are ongoing efforts, our partnership with BioVac in South Africa to help with manufacturing, but there is so much more to be done, and we can only do that with community efforts. Thank you.
thank you very much. I have my marching orders. I think the overarching message is next year, we will have more equity in the program. We will have better representation in the program. And we will not be having the same conversation at the same level. Thank you very much.